Hi, and welcome to another ICS Impulse video. I'm Wendy Crumley-Welsh, Product Manager for ICS Impulse. And today what we're going to be talking about is performing a proper head impulse, how to avoid the common mistakes, and also interpretation of the data and looking at the data. Now, just so you know, there are several other videos to look at as far as performing the head impulse, doing the calibration, pupil detection, and also the analysis video. So those are other videos you're going to want to look at as well, but this one gives you a few more tips. So we're going to talk about performing a proper head impulse. Now, obviously, performing a proper head impulse maneuver properly assists in acquiring quality data and proper diagnosis. So I hate to say it, but you know, garbage in, garbage out. If you're not doing a good job in collecting your data, then you really can't use it to properly diagnose a patient. So let's talk about head rotation. Proper head rotation must be performed. In order for accurate diagnosis, it must be, for lateral, 120 to 250 degrees per second. It cannot be slower than 120. The data will not be accepted. The other thing is when you're doing head impulses too slow, you're not really isolating the left side from the right side. So now it's 120 to 250 degrees per second for lateral, 100 to 200 degrees per second for LARP and RALP. That's left anterior, right posterior, right anterior, left posterior. You want to use varying velocities, but the same velocities for both the leftward and the rightward head impulses. So you don't want to do all the leftwards at 200 and all the rightwards at 100 or 150. You want to make sure that the velocities are the same for the left side and the right side. They're typically passive. That means the tester is manipulating the patient's head. Now, there is some research out there about active head impulses for rehabilitation purposes, and that can be done. But typically for assessment, we're doing passive head impulses. So the tester is moving the patient's head. And you want to make sure they're unpredictable. Why is unpredictable important? Why do we not want the patient to be able to anticipate the head impulse? Well, we don't want the patient to try to compensate for their disorder. Randomizing head impulse direction mainly affects the catch-up saccade pattern. If the head impulses are completely predictable, patients will do better in making covert saccades or compensating for their disorder. In order to show the deficit, which is the purpose of the test, it's better to randomize the order. ICS Impulse, it's bringing diagnostic accuracy and efficiency into balance testing. We want to make sure you perform the test properly so that you have accurate diagnostic results as well. As you see here in the picture, the new powerful gold standard for vestibular ocular reflex, the ICS Impulse, was built on the work of Drs. Himagi and Kurthoys. Impulse is the only device validated against scleral search coils at the time of this video. What you see here is the ICS Impulse goggles, and then on the patient's eye is the coil, and then the bite bar to measure the patient's head movement. And then you see here the full system being set up so that they were simultaneously collecting coil data along with goggle data. There's several components that make collecting head impulses possible with this device. The first thing that's important is the fact that they're lightweight goggles. They're only 60 grams. You want lightweight goggles because you don't want the goggles to slip during head impulse testing. The highest speed camera at 250 Hz is very important for picking up those catch-up saccades. Built-in dual-axis gyroscope is obviously measuring the head movement. No slippage with a secure fit. Again, no slippage is very important. Superior software-based pupil detection to make sure that the pupil is always detected so that you can capture those catch-up saccades. And last thing is software algorithms that identify good head impulses and good data. And there's two algorithms in here, and we will talk about those two algorithms in more detail in the analysis video. But there are two algorithms in the system that assure that good data is collected, and therefore only good data is analyzed. Let's talk now about ICS Impulse versus visual observation. Why is ICS Impulse superior to visual observation? Well, ICS Impulse can identify covert catch-up saccades. It validates that the head impulse is performed properly. Both sensitivity and specificity are 95% for ICS Impulse, and sensitivity is estimated at 70% for visual observation. Reduction of false negatives. Again, you don't want to be missing those covert catch-up saccades and saying that the patient is normal because you couldn't see the covert catch-up saccades. So you're identifying patients as normal who are truly abnormal when you use visual observation. With ICS Impulse, you identify both the overt and the covert catch-up saccades and don't misidentify anybody. Objective analysis with normative data. It's documented head impulse test results. So you have documentation that the test was done and this was the results, instead of just a handwritten note, which you would have with visual observation. And better patient comfort during testing. When you're doing visual observation, you have to do quite large head impulses. And what I've seen out in the field with neurologists who currently do visual observation is their head impulses, when they start to use ICS Impulse, are over 300 degrees per second. With ICS Impulse, you don't need to make that big of a head movement, and you shouldn't make that big of a head movement, because actually with ICS Impulse, that big of a head movement causes artifacts. So you want to keep your head impulses in that 150 to 200 degrees per second. So everybody who's out there doing visual observation, you need to slow down and do smaller head impulses. Obviously, smaller head impulses means that patient comfort is increased. So the smaller the head impulse, the more comfortable the test is for the patient. Let's talk about goggle fit. When you get ready to place the goggles on the patient, you need to make sure you obtain a new face cushion. Face cushion is single use only. If you've reused the face cushion and you have an old face cushion which looks limp, or the foam is not adhering to the plastic part of the insert, this will result in slippage. So you need to make sure that you have a good quality face cushion when you're doing the testing. Again, it's intended that these are single use. You need to make sure you secure the goggles, making sure the strap is tight and the goggles do not slip. Goggle slippage, again, results in artifacts in the data. And then the other thing that's very important is there's a clip on the cable that should allow you to clip the cable that comes from the goggles to the interface box onto the patient's shoulder or onto their collar. You definitely want to clip this cable on there. Anytime you're doing head impulses and that cable is hanging there without being clipped to the patient, the pulling on that cable can cause movement of the goggles and cause slippage. So it's very important that you clip that cable to the patient's shoulder. Again, all of these things, this is just reiterating some things that I saw people were not performing even after viewing the training video, but these are important aspects of performing a good head impulse test. Again, you can view the full training video on ICSimpulse.com. One other thing regarding the training video on ICSimpulse.com, this training video is available in English and German, and it's subtitled in French, Spanish, and Italian. So let's look at goggle fit again. If you can look here and see where the arrows are pointing, you see there's gaps between the patient's face and the actual foam cushion. That's a bad goggle fit. If the goggles fit the patient like this picture, you're at risk that the goggles will slip during head impulse testing. What you can try to do is take out the face cushion and use the goggles without the face cushion and see if they adhere to the patient's face more appropriately. In my experience with the ICS Impulse system, it's very rare to find a patient that the foam cushion fits in this manner, but I want you to be aware of it. It's always a good idea to look at the top of the patient and look to the side of the patient and make sure that foam cushion is fitting appropriately to the patient's face. Here's an example of a proper goggle fit. You can see there's no gaps from the side or from the top, so that face cushion is adhering to the patient's face. And this is what we see most of the time with most patients. Now let's talk about patient setup and testing. The patient must be at least 1 meter from the fixation dot. Why is that? Having a very close target activates convergence. The eyes have to cross in order to look at the dot. Activation of convergence system may interfere with vestibular ocular reflex. In addition, a close target adds a linear component. The eyes move sideways relative to the dot. This effect becomes smaller with increasing distance of the target. So that's why it is recommended that the patient be at least 1 meter away from the fixation dot. You can easily find that answer again on the frequently asked questions as well. You also want to make sure you never touch the goggles or the strap when performing the head impulse test. If you move the goggles during the test, you can move the camera, resulting in a camera losing track of the pupil. This would result in potentially missing catch-up saccades. Again, never touch the goggles or the strap when performing the head impulse test. Let's talk about proper pupil thresholding. Now, the only way the goggles can track the eye is if it can track the pupil. And pupil thresholding is within your control. Now, obviously, if they come in with a lot of mascara or thick eyeliner, you want to remove that. You want to make sure that you're doing everything within your control to make this data as clean as possible. Now, the other thing is you should see a big white pupil on a black background, or if you're in grayscale, you see the pupil on the grayscale image. You want to make sure that pupil is as round as possible, and that when you look at the trace on your window in the software, that trace is fairly flat. If you have a trace like in Head Impulse that's very up and down, up and down, up and down, jaggedy, see if you can tweak by using the plus or minus buttons here and make that trace less jaggedy, because that's just noise that's going to interfere with your actual eye movement, and you want to make sure there's as little amount of noise as possible. So I always click auto threshold, and then I tweak from there by using plus or minus. Now, make sure the patient's eye is nice and wide open before you click auto threshold. If they happen to blink and their eye is closed when you clicked auto threshold, obviously it's not going to find the pupil for you. And after you do your thresholding and you think you've got a nice pupil, have them look at the laser dots on the left side and the right side and look and see, is that green cross tracking the pupil? The other thing is, make sure the pupil is in the center of that green ROI box. If it's off to the side, you won't have enough room to do your head impulse to move, and if that pupil touches the edge of the box or moves out of the edge of the box, then you don't track the pupil and your data is garbage. It's also going to reject if it's hitting the box. So you want to make sure that pupil is in the middle of the box. Now, how do you ensure you're doing proper head impulses? You want to make sure that you hold tightly to the head. You can do this in one of two ways. I have a tendency to push down at the palms and then hold at the tips of the fingers. Some people like to hold more at the tips of the fingers, but you want to make sure you hold onto the head firmly when you are doing your head impulses, because you are going to want to do a short amplitude, so from point A to point B. You don't have to move the head very much, only from 10 to 20 degrees, but you want to make it quick, 150 to 200 degrees per second. If you think about it, it's like rolling a pencil in your hand. You will push with one hand and pull with the other hand. So when you do a head impulse, hold on firm and quickly move the head. Hold it there and then move the head back to center. It is a quick, abrupt motion. Then you notice from here to here is not much of an amplitude. It does not have to be a very big amplitude. Even with this very small amplitude, the cameras are more sensitive than the naked eye and can pick up an overt or covert catch-up saccade with a small 10 degree or 20 degree amplitude. But also notice that as we move from here to here, it is a fast movement, 150 to 200 degrees per second. If you have never done head impulses before, you're going to need to practice. It is best not to practice on the patient. This looks a little odd, but you can be creative. You can get a melon from the grocery store or use a ball. And what you can do is set up the ICS Impulse system so that it does not track the eye at all. Make sure you slide the auto threshold over and make sure it is not picking up any noise. Click default for the calibration, then practice your head impulses on your fictitious patient. So do your head impulses and actually see your head impulses in the lateral window screen. Don't be alarmed if the data doesn't analyze, or very few head impulses actually analyze, because the analysis algorithm actually looks at the head movement as well as the eye movement. So a lot of your head impulses when you practice will be rejected because you don't have any eye movement. When you're doing your head impulse, you want to make sure you're looking at the real-time window. This window allows you to monitor both head in red and eye in green while performing the head impulse test. Same window we looked at when we were monitoring the eye during calibration. Why is the real-time window important? It assists in identifying if spontaneous nystagmus is present, assists in identifying if the patient is cooperative and staring at the fixation dot. If the patient's looking around everywhere, you'll see the green line will not be smooth. It'll be moving up and down. Assists in identifying if the patient is staring at the fixation dot at the end of the head impulse. Again, are they maintaining fixation on that fixation dot, or are they looking around? It is important the patient keep looking at the fixation dot, keep their gaze stable, and do not blink during the head impulse test. An eye blink will look like a spike in the real-time trace window. The other window, the lateral impulse window, is also very important. The head trace is displayed in red with negative velocities if the movement is towards the right. The head trace is displayed in blue with positive velocities if the movement is towards the left. The eye trace is still represented in green, and white dots display along the y-axis to indicate the velocities of impulses collected. So again, if you look at these white dots, they're between 100 and 200. That's good. You want most of your impulses to be between 150 and 200. That's the sweet spot. Why is the lateral impulse window important? It assists the user in performing good head impulses by comparing head impulse data to the gray training curves. Displays velocities of head impulses collected, which helps tester know they are varying the velocity. It is very important that the physician-technician performs proper head impulses. There should be no more than approximately 20 rejects. It is recommended that the physician or technician practice prior to testing patients. And physicians who perform head impulse using visual observation will have to be retrained. They typically, again, are used to doing head impulses at a velocity above 300, and we want a velocity between 150 and 200. Now, one thing we implemented in Otosuite Vestibular 4.0 was the training mode. So what you actually do is you go to Patient List, go to the Import tab, and import the training mode demo data into the patient list. And what that does, under the demo data, there is a file called training mode, and it brings that file into your software. So you hear training mode. And then you open the training mode. So you click on it and you open it. And what it actually does is now the tabs are highlighted in orange. So you're sure that you're in training mode. And why do we build training mode? Well, when you're doing head impulse testing, and it's mostly for head impulse testing, but you can use the training mode patient to train on any of the modules, but we actually turn on the center laser. Now, what you're going to do is you're going to put 3 dots up on the wall and 3 fixation targets. And there you have the center fixation target, and then the other 2 are about 6.5 inches or 16.5 centimeters from center in a row. And then that center laser should be pointing straight at the one in front, and as you do the head impulse, watch that center laser, because you should be making a dead stop to the right or to the left. If you see that you go to that left or right fixation target and then come back to center, what you're doing is you're creating overshoot, and you want to avoid overshoot. The other thing is you want to make sure that that line is fairly smooth and that it's not bouncing up and down and you're not moving the head vertically as well as horizontally at the same time. So those 2 dots with the center laser on is to help you train to do a proper head impulse. So again, that center laser is on during training mode, and it's to assist you in reducing overshoot. You do not want to be performing overshoot, because what you're doing is, if I was going leftward, I'm stimulating the left canal, then I'm bringing the head back to the right and I'm stimulating the right canal, and you don't want to do that. You want to isolate the left side from the right side. Okay? So it helps you practice your head impulse and do a better job in learning how to perform a proper head impulse. So again, here you see the center laser is on, and now you should see, start in the center, do your head impulse, stop to the left, start in the center, do your head impulse, stop to the right. Let's talk about common mistakes. So in your head impulse system, there is the interpretation guide, and the interpretation guide talks about artifacts, and it also talks about looking at the data or interpreting the data. So common artifacts: the eye leading the head, poor pupil detection, overshoot, and then also wrong plane stimulated. Now what I'm going to show you next is a video that I actually put together for our customer sales people and our audiologists who work for Otometrics. And so I put this together so that they could then help customers in the field when they see poor quality data. So this video is going to cover the eye leading the head, the poor pupil detection, and the overshoot. The next thing I want to show you is the eye leading the head. And this honestly seems to be the biggest problem. So let's go over here. I'm going to type in data. You may recognize this file if you've looked at the analysis video, because I use this file when explaining the reanalysis feature. And we need to turn our eye back on. Okay. So you can see here the data is all over the place. I mean, why do I have left gain up here at 1.6 and a left gain down here at 0.6? That's bad. If the data is collected correctly, the data should be clustered around each other, not sprawled out from top to bottom. So if we click over here, and we want to be able to see the eye and the head, and when you're looking for the eye leading the head, it's easier to do in the version of software that's getting ready to release in 2.0. So again, I want to get on the trace window, and I'm going to use my up and down arrows and look through these traces. And you can see here, see how the eye, the peak of the eye, comes before the peak of the head. That's what I mean by the eye leading the head. More often than not, this is due to goggle slippage, just pure goggle slippage. And again, you're going to, when you read the document that goes along with this, you're going to see all the reasons that can cause the goggle to slip. So if you see customers whose data looks like this, you're going to want to go through that whole list of things with them. But what's happening is, let's go through, let's find one of these. It's very obvious. Here we go. So what happens is that the eye trace is so sharp, and like Ian calls them like a saccade, he calls it a stalactite. But because this back end is so inclined and the eye movement is so sharp, the desaccader algorithm thinks it's a saccade. So it's going to take that saccade out, and then you're left with the VOR component, which is this little green line here. And then when you do the area under the curve, the head is much bigger than what's left of the eye, and you get a low gain. Now let's look at the one that's really high. Okay, so the one that's high, the eye trace is much broader. It's not as sharp, so it doesn't think it's a saccade. And therefore, when it calculates the eye over the head, the area under the curve, the eye is much bigger than the head, and you get this high gain. This is just bad data, to be honest. You've got to make sure you don't have goggle slippage. So read the document. You'll go through a list of all the things that this could possibly be. And this is easy to see while you're doing the head impulses. So in the real-time trace, if you see the eye, the green trace leading the head, which is going to be the orange or purple or blue trace, depending on which plane you're testing. But if the eye is leading the head, then you need to stop and check things. Make sure your strap's tight. Make sure your cable clip is clipped on the right side. Make sure you have a good face cushion. Make sure the face cushion, and there's no gaps between the face cushion and the face. So all these things. The other thing that can cause high, now this isn't the case in this data because we've got high and low gains. But if you see a bunch of high gains, is that person sitting closer than a meter to the fixation dot? If you sit too close to the fixation dot, then you get convergence, or you become cross-eyed, and you will get higher gains. So there's lots of things to rule out as to why this is happening, but anytime you see the eye leading the head, you got to suspect that there's goggle slippage occurring. Okay, next thing, pupil detection. Oh, here we go. Poor pupil detection. Okay, let's turn these back on so you can see the eye and what a disaster this data is. We'll bring up the gain graphs as well. Okay, so you see gain. Most of it's elevated or above 1.2, especially in LARP and RALP. But you can also look at these traces. Now, if you only got this in a PDF or a screenshot, you would have no idea whether all of this is in one trace, like really noisy in one trace, and should have just been deleted, or if those are actually individual saccades. That's why it's important that you get the XML file and really look at it. Let's come up here and let's look at the lateral, because this is what's really bad. So if we look at this data here, I mean, we can see this eye trace is up and down and all over the place. We've got some head impulses that are way too large, which means that could also cause goggle slippage. But we're not really seeing the eye leading the head with these. What we're seeing is just really bad pupil detection. See, if I go back, let's just go over here and let's take the eye out. Head impulses, I mean, while they're not the most beautiful, there's an example of overshoot, which we'll talk about in a second. You know, for the most part, the up and down is clean, the overshoot looks bad. And they're quite large. You know, but the biggest problem with this data is the eye traces. So we can go back, we can turn on the eye traces. So you see here, now all I have is the eye trace on and it looks quite junky. The eye is all over the place. Now what can be causing this? Well, either one, the patient doesn't understand the task of staring at the fixation dot, or two, the pupil detection is set poorly. So a couple of things that you need to make sure of. One is you do not want to test in a dark room, because if you test in a dark room, it makes the pupil larger, which makes it more difficult staying in the ROI box. So a normally lit room is what you need. The second thing is you don't want to be testing with the person facing a bright window or a bright light, because then the IR LEDs and the camera can't read the pupil off of the dichroic mirror. So you want to make sure you have optimal light, but that you don't have really bright light like a window right in front of them. Now, one trick you can do that if the person does have really big pupils, and Lee McGarvey does this, is you can get a pen light and just kind of shine it so that it constricts the pupil. Some people need that, but not everybody needs that. The other thing then is make sure that they're actually doing a good pupil threshold, or click the auto threshold. If that isn't good enough, then I suggest using those little plus minus buttons to tweak it to get a better pupil detection. And then turn on the laser dots, have them look left at the laser dot, have them look right at the laser dot, and make sure that pupil's tracking before you go on to calibration. So this is obviously, if we go through these traces, I mean, we can see the eyes all over the place. So either the camera's having a hard time tracking the pupil, or the patient is not doing what they're supposed to be doing, which is staring at the fixation dot. You want to make sure that they stare at that fixation dot through the whole entire test, even the end. So if we come over here, we can see that this is just junk. So these flat lines, let me go back. Okay, see like this flat line here? That could be one of two things. Either the pupil is now out of the ROI, or is touching the edge of the ROI, or the person has their eyes closed. So obviously this data, it's not really interpretable, to be honest. The pupil detection is so poor that how would you know if there was a saccade there or not? Okay, next thing is overshoot. We're going to look at two different ones. So here's the first one. And when we look at overshoot, go to display and turn off the eye, and let's turn the head back on. Here we go. We'll bring this little guy up here too. Oops. Sorry, obviously this data has a lot of issues, but what I really wanted to show you was the overshoot, and I guess the best one to look at here is the lateral. And that's an excellent example of overshoot. So what happens with overshoot is that you're going in the direction you want to test. In this example, it's leftward, but you're coming back to center too quickly. And basically, there's two issues there. One, you're stimulating one canal, then you're stimulating the other canal. So how would you know if this person has unilateral loss? But the other issue is that if the eye is moving with the head, you've moved the eye away from the fixation dot, but then you move the eye right back to the fixation dot. So you're not going to see this person have a catch-up saccade anyways. So there's a lot of issues, and again, this is documented or put into the document that goes along with this video, but overshoot is not optimal for being able to diagnose a VOR disorder. So again, if the person's using version 1.2 or above, they're going to get the operator feedback and be told there's too much overshoot. They need to understand not just to ignore that. I mean, sometimes you can do a really poor head impulse and it will reject it, but a lot of times the too much overshoot doesn't reject it. It's just trying to tell the person, hey, you got too much overshoot. So it's important for them to understand why that's a problem, and they're not going to be able to diagnose their patients adequately if they're not performing the head impulse properly. So we'll go back over here. And again, you get this big spread of gain, there's a problem. You shouldn't have half of them in the normal range, half of them in the abnormal range. So if someone comes to you and says, you know, I'm not getting good data, because typically our customers, unfortunately, will look at the gain graph more so than the traces, then you've got to explain to them why. And typically it's either slippage or the eye leading the head, they're doing the head impulses too slow, the pupil detection is poor, or they have overshoot. And again, it's just a little more retraining and they're usually good to go. So hopefully those videos and explanations help you. If you get customer concerns, please ask for them to send you the XML file and then open it up and go through it looking at the eye, the head, and see what's occurring. And then compare it to the document that I've done, and you can figure out why, what the problem is, and how to solve it. That's it. And the last one that wasn't covered in that video is the common artifact of wrong plane stimulated. So during LARP and RALP, the vertical head impulse test, the head should be turned 35 to 45 degrees, and the patient should be looking back at the fixation dot. The head impulse should be performed in the plane of the canals being tested, not towards the nose. So you should be going towards the plane of the canals, not towards the nose. When you perform the head impulse towards the nose, you're stimulating both sides at the same time. And you want to be able to isolate the canal. So you want to isolate the left anterior from the right posterior and the left anterior from the right anterior. So you don't want to drive towards the nose. You want to drive within the plane. And there's a very good LARP and RALP video to watch that teaches you how to do this. But if you see in your data that the eye trace is shifted to the right of the head trace, the head impulse was directed more towards the nose, and that's wrong. And there's a very good article by Lee McGarvey and others that talks about this in Frontiers. Now let's talk about reviewing data. So in reviewing data, you need to determine the shape of the head velocities, determine the shape of the eye velocities, look at the catch-up saccades, look at the VOR gain, and then we'll also talk about spontaneous nystagmus. So first thing is determining the shape of the head velocities. You want to check that you've performed good quality head impulses, and the best way to do this is look at the shape of the head movement and spread of impulses plotted on the gain graph. So when you're looking at the 2D, you can go under display and turn on just the head, and then you can look at just the head traces and not have the eye on the screen. And you can look and see, are they bilateral? Do they look like they were done in the same range? Are the velocities the same? 120 to 250 for lateral, or 100 to 200 for LARP and RALP. But if you look at the peak of the velocity of the head movement, were they the same on the left side as on the right side? And you can also see this in the gain graph here. Were the velocities basically spread over the same area? You don't want all your lefts down in the low end and all your rights up in the high end. And you want a good range of velocities. So this is an example of good quality data. Then you want to look at the shape of the eye velocities. If the vestibular reflex is intact, the eye velocity should be proportional to the head movement. So the eye and the head should be laying on top of each other. But if the eye movement looks saturated or clipped, so you see how this eye movement, the green VOR is very low in comparison to the head. And in the 2D, you see this very nice tunnel here. Then you know that this is abnormal VOR and the gain should be low. So this is an abnormal response. Regarding catch-up saccades, if catch-up saccades are present, for them to be significant, they should be large in amplitude, consistent across many head impulses you perform, and they can occur, and they will not occur any earlier than 70 milliseconds. In Otosuite Vestibular 2.0 software and newer, true catch-up saccades will be in red, if the algorithm determines they are significant, and some small catch-up saccades can occur in patients with normal vestibular ocular reflex. So here on the left side here, you see that you have data that's within normal limits. And then over here, you can see that you've got catch-up saccades and you've got this clipped VOR. Now notice, even though you've got a few saccades here, that VOR is almost one-to-one with that head. That's not abnormal. But sometimes you will get a couple of little catch-up saccades in a normal person. But here, the VOR is obviously much more reduced than the head movement, and you've got these big catch-up saccades. This is an abnormal finding. Okay, you should have low gain as well as these beautiful catch-up saccades. And it's very important to look at the catch-up saccades first. So one thing that's covered in the analysis video is that if you have a unilateral loss, sometimes if the side that's impaired is so greatly impaired, it will pull down the good side because that side that's impaired is not inhibiting when you're exciting the good side. So what you'll have is you may have some catch-up saccades, but what you'll notice in the good side is you do not get this clipped VOR. You may get a little bit of a reduced VOR. It won't look as beautiful as this, but it won't be clipped like this. And that's a normal response, even though you've got some catch-up saccades and a little bit lower VOR. But that's the normal side. It's just that the impaired side is dragging down the normal side. So check that out on the analysis video. The next thing is VOR gain. So again, this is actually showing you something very similar to what I just talked about. There's normal values in the ICS Impulse for VOR gain. So for lateral, it's 0.8 to 1.2, and for LARP and RALP, it's 0.7 to 1.2. If VOR gain is higher than this, it is usually artifact. So we want to be aware of some unilateral weaknesses may reduce the VOR gain in both ears, so refer back to the eye movement trace to confirm whether it's unilateral or bilateral. So here's the example that I was just explaining to you. Here's a unilateral loss. The left side here, you can see there's a VOR, but it's a little bit reduced compared to the head. And there's a few saccades here. See, it's in the gray range. And we would go, well, gray, is that abnormal? This is not abnormal because we actually, what's happening is this side, the right side, is pulling down the left side. So you can tell because the VOR is not clipped. It looks nice, shaped like the head. It just happens to be a little bit reduced. Over here on the right side, we've got these beautiful catch-up saccades, and we've got this very clipped VOR in comparison to the head. And this is definitely abnormal on the right side, but the left side is not impaired. In a bilateral loss, you see here's two, they're both low, but look, both of these, the right and the left side, are clipped, and both have these nice amplitude saccades, and they do throw a saccade with each one of the traces as well. And this is indicative of a bilateral loss. Now the other thing you can do is shimp. So shimp would also help because then you can look and see, especially in this example here where you've got some covert catch-up saccades. With shimp, the coverts are do not affect the VOR. There are no covert saccades in shimp. And then you can do the shimps and look at the gain as well. And then you can also see if there's any residual function in these, in the left and the right side of this bilateral loss. Last thing is spontaneous nystagmus. So unlike catch-up saccades, spontaneous nystagmus may occur before and or after the head impulse and are usually smaller in amplitude than catch-up saccades. You will normally see them going upward in one impulse direction and downward in the other. For nystagmus that beats away from the site of lesion, spikes appear in the opposite direction of the VOR eye movements, following head impulse towards the intact side. So on the intact side, you typically see them beating downward. On the impaired side, you would see them beating upward. You want to be aware of overshoot, though, because if you have overshoot, which we've already talked about, it can cause saccades in the opposite direction and look like spontaneous nystagmus. So if you're overshooting, then the person is going to try to look back the opposite direction at the target. So here you see on the right side, this is all spontaneous nystagmus. The left side, actually, you don't see much spontaneous nystagmus, maybe a little bit at the end here. But we've got nice, beautiful results, that clipped response again, and these beautiful catch-up saccades. So again, quality data equals quality care. So make sure you're doing everything in your possession to make sure that the data is collected appropriately, you have good pupil detection, you do the head impulse maneuver properly, and then you interpret the data accurately.